that with his attitude against or to leukemia managed to increase by 3,000% the bone marrow donation from social media. Sadly, he lost his battle, but his contribution is legendary. Upper extremity deep vein thrombosis accounts from 4 to 10% of all cases of DVT. The incidence is increasing mostly due to the widespread use to the central venous catheters. Secondary upper DVT is much more frequent than primary, accounting for around 80% of cases. Information about clinical outcomes of upper DVT is derived from only a few studies with many shortcomings. As we know, there are a lot of complications associated with upper DVTs. However, most clinicians believe that they are less dangerous than lower DVTs. Information about upper DVT is scarce and poor, so clinical practice guidelines are extrapolated from lower DVTs or PE studies. For example, ISPH guidelines for catheter-associated upper DVT, likewise in the ACCP or American Society of Clinical Oncology guidelines. If we use technology, like Pablo, we can find the following information in PubMed. In RIETE in 2015, look for a score for outpatient treatment for upper DVTs, where cancer patients were with or without metastasis were a important consideration. Recently, Dr. Craig Powell studied upper DVT where cancer patients were a high-risk group with a different diagnostic management. In this study, we learned that catheter-associated upper DVT had complications. In this recent review, the presence of catheter increases risk of upper DVT in 7-fold, and cancer increases risk in 18-fold. In this paper, they also compare upper and lower DVT. And they realized that upper DVT had less complications than lower DVT. Is it the same in cancer patients? Well, the Swiss researchers found that higher mortality rate was due to the spread of cancer. Here, our Dutch colleagues found upper DVT and cancer in 44% of cases, and central venous catheter and upper DVT in 43%. Among cancer patients, there was a higher risk of recurrences, bleeding, and mortality. However, the contribution of the PE in the mortality was unknown. What data have we got in RIETE World? In 2016, RIETE compared upper and lower DVT, and we found similar results between both. Actually, today, we are able to analyze 73,000 patients, of which almost 7,500 have DVT and cancer. Of those, 6,461 had lower DVT. 636 had catheter-associated upper DVT, and only 393 had non-catheter upper DVT. Highlighted in red shows the statistically significant. As you can see, upper DVT were younger. Catheter-associated upper DVT had better renal function, higher percent of anemia, thrombocytopenia, and thrombocytosis. Non-catheter upper DVT had more metastases and mostly associated with lung and breast cancer. Of those, also catheter-associated upper DVT were recently diagnosed with cancer. The most of patients were treated with low molecular weight heparin. However, upper catheter-associated upper DVT received lower dose. For long-term therapy, low molecular weight heparin were used more in upper patients. In my opinion, this is the most important slide of this presentation. Clinical outcomes during anticoagulation in event per 100 patient years. This table shows PE, pulmonary embolism, DVT recurrences and bleeding were similar in lower and upper DVTs, and a higher mortality rate in non-catheter upper DVTs. As you can see, from respiratory insufficiency. We thought it was interesting to focus on pulmonary embolism during anticoagulation, as this multivariable analysis shows PE is more frequent in younger patients with metastases and with recent diagnosis, independent of site of cancer, site of DVT, or type of anticoagulant treatment. What's the next? In my conclusion, upper extremity deep vein thrombosis in cancer patient is relevant. Upper extremity deep vein thrombosis during anticoagulation has similar recurrences and bleeding than lower DVTs. During anticoagulation, catheter-associated upper DVT has lower death rate. Non-catheter upper DVT has higher death rate with respiratory insufficiency. Pulmonary embolism is more common in younger patients with metastases and with recent diagnosis during anticoagulation. And finally, the most important thing, we have an obligation to help resolve all these questions with our most powerful tool, RIETE. So, can you include more patients, please? This sends my tribute to Pablo Raed. Thank you very much.
Thank you very much, Vladimir.